Hi there, my name is Morgan Larocco. Welcome to my 3P Live binder. I chose to focus on the geriatric patient population as this is the population segment that is growing fastest in this country, and they do have some unique qualities to caring for them different from the general adult population. So when starting your geriatric patient assessment, you would obtain a complete health history, including all medical and surgical history. You can understand that a patient in their 80s, the procedure that they had done in their 30s might not be relevant anymore. However, you would want to get a complete list to get a thorough picture of your patient. Of course, you would need a comprehensive medication list. This can get extensive in your elderly patients, and you would need to be able to really analyze and see what risks they are at in terms of side effects for polypharmacy and things like that. You would then need to get a complete set of vital signs. It might be beneficial to obtain an orthostatic blood pressure series in order to be able to rule that out in your geriatric patient population. There are also several items of your physical assessment that are unique to the geriatric patient. So your patient is going to be greater than 65 years old is what differentiates them from the adult. And there are a variety of expected physical changes that you can be looking for. So in general, your geriatric patient is going to have an atrophy of subcutaneous fat. This is going to occur in the face, so they're going to be appearing to have a sunken in face, and that is an expected finding. Also, on your head region, the dentition is going to worsen. So perhaps they were not keeping good care of their teeth. Their teeth need to be pulled. They could have a lack of full teeth or lack of all teeth altogether, and of course then they would have dentures. And there are a lot of issues that come with poor dentition, so that is an important piece to be evaluating as well, and do a dentist referral when needed. Your patient's sense of taste and smell are also decreased, which usually isn't too big of a deal. It can be when they might have a lack of appetite and they want to be able to taste something good. Often though, it is okay because they might be on so many medications that if they can't taste the meds or the aftertaste from medications, that usually isn't too big of a deterrent for them. About half of geriatric adults develop a systolic murmur. So that is good to know when you are doing your cardiac assessment. Abdominal musculature has thinned and gastric motility has slowed. So their core muscles are weakened and your GI motility is slower, so they're nearly all going to be at risk for constipation and other GI related issues. So not just in the face, but throughout the body, the subcutaneous fat stores are significantly decreased, and this then increases the bony prominences, which can be an issue with pressure ulcers when they are at such high risk for developing so quickly because these bony prominences are more pronounced than a healthier, full-figured adult. Often you're also going to see kyphosis, which as we know is the outward curvature of the spine in your patient. Also, nerve impulse conduction is slowed. This results in a slower reaction time. So maybe there isn't an actual true delay, but they're just slightly slower in their response or their actions. What you often will see is a hesitant gait with walking, which can be a really good thing. They're more thinking of their next steps to hopefully prevent the fall. In general, as we know, the elderly patient's skin becomes thin and frail, at risk for skin tears, breakdown, bleeding, which can lead to a trickle down of other complications, of course. For your geriatric patient, a focus would be a thorough, comprehensive fall risk assessment. Anyone is at risk of falls, but of course your geriatric patient, for a lot of the reasons that I've just listed, is at a higher risk of falling. The focus must be on preventative efforts, aggressive preventative equipment, and services in place to hopefully prevent that fall and keep your patient as independent, as mobile as possible. Also, you would want to do a dementia screening. Oftentimes, dementia might not be noticed until it's farther along, but if we can do a thorough screening and perhaps catch it when it's in the beginning phases, we would be able to slow progression of this dementia, again, trying to keep the patient as independent as possible. For this, we would start with the mini mental state exam and go from there as findings were to surface. We're also going to look at the family support. Many elderly patients are alone, but the majority of them do have some family somewhere that can be a source of support. So we would identify what resources are available or what other resources that they might need. Finally, it is good to talk with your geriatric patient about end-of-life wishes. Even if they're not necessarily there yet, that's when it's a good time to have that conversation, to start to prepare and maybe even get documents written while your patient is fully oriented and aware of what's going on and what their wishes are at that time. Thank you for your attention, and I hope you enjoy the rest of my presentation through the geriatric patient population. Thank you.